So this morning we'll continue from where we left last time. We had started on anatomy of the digestive system. And I told you that we can divide the components of the digestive system into two large categories. There's what we call the histology. This refers to the path that is followed by food. So we call it the alimentary canal or the gut. But I also told you that we have what we call the extrinsic glands of the digestive system. This refers to the organs or glands which are not necessarily within the wall of the GIT, but provide their secretions into the lumen of the alimentary canal. So they include the salivary glands, the pancreas, liver, and gallbladder. In terms of objectives, I outlined to you what we needed to do. So last time we looked at we named the components of the histology, starting from the oral cavity all the way to the anal canal. And so you know that in order. We then talked about the histological structure of the GIT wall, where we said that there are 4 histological layers. From inside out, we have the mucosa, then submucosa, then muscularis propria, and finally, the adventitia or serosa. Then we were now at that particular objective, where of the various parts of the whole GIT. We had already talked about some parts, but we didn't talk about others. The other objectives that need to be covered, therefore, talking about the anatomy of the exocrine glands of the digestive system, and also explaining the splanchnic circulation. So let's speak from where we left, which is objective number 3. And in that objective, we had already talked about the anatomy of the oral cavity, of the pharynx, and esophagus and stomach. So today we continue from there. And basically what we want to do today is very brief. We'll talk about anatomy of the intestines, where we're going to look at the small intestines as well as the large intestines. Let's begin with the small intestine. So in terms of segments, the small intestine has 3 components. We have the duodenum, we have the jejunum, and you have the ileum. Now, in terms of functions, the small intestine has 2 key functions. One is the digestion of food substances. Food is particularly digested within the duodenum as well as within the jejunum. And then we have absorption of nutrients. And nutrients are particularly absorbed in the ileum. So those are the components and functions of the small intestines. The small intestines are suspended by what we call the mesentery. The mesentery is a double layer of the peritoneum that suspends the intestines, and particularly all the segments of the small intestines are suspended by the mesentery except the duodenum. So the duodenum is not suspended by the mesentery, but jejunum and ileum are suspended by the mesentery. This is the mesentery, or real time, this is the mesentery. This suspension the mesentery contain a number of things. The blood vessels that supply the intestines run within the mesentery. The lymphatics that drain the intestines also run within that particular mesentery. The nerves which supply the intestines also run within the mesentery. So the mesentery is an important thing that usually suspend the intestines, and it contains some things. The mesentery also contribute to putting into compartments the abdominal cavity. So what are the blood vessels which supply the small intestines? I've told you that we have the duodenum, jejunum, and ileum. The duodenum has dual blood supply. Usually there are three arteries which arise from the aorta to go to the digestive system. We have what we call the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. The duodenum enjoys blood supply from both celiac trunk and superior mesenteric artery. So the arteries don't really supply the duodenum directly, but if you trace the vessels which reach the duodenum, eventually they either arise from the celiac trunk or the superior mesenteric artery. And we'll be seeing why the duodenum receives those two sources of blood supply when you look at the embryology of the digestive system. But in a nutshell, the celiac trunk is the artery of a segment we call the foregut. And so for that reason, the derivatives of the foregut are supplied by the celiac trunk. And duodenum partially comes from the foregut. That's why it receives vessels of the foregut. Superior mesenteric artery is basically the artery of the midgut. And duodenum partially also arises from the midgut. But the rest of the small intestines only arise from the midgut. And so for that reason, the jejunum and the ileum are exclusively supplied by branches of the superior mesenteric artery. Those arteries run within the mesentery, as I mentioned to you earlier. Maybe in this image, you can appreciate something about the duodenum. So usually the duodenum has 4 segments. We talk of the first part, commonly known as D1, the second part known as D2, the third part known as D3, and the fourth part known as D4. So this first part is a part that is arising from the stomach. It's the highest part. The second part is the part that is going down, so we call the descending segment. The third part is a part that is running transversely, so we call the horizontal segment. And the fourth part is the part that is ascending. We call it the D4. So from there, then we have the jejunum. This junction here is called the DJ junction, duodenojejunal junction. And this particular junction demarcates what we call the upper GIT and the lower GIT. So anything distal to this duodenojejunal junction forms part of the lower GIT, and the part proximal to this is the upper GIT. We can divide the GIT into upper GI and lower GI. And I want you to familiarize that terminology because clinically it will become important. There are times that you'll be describing types of bleeding in patients and you talk of upper GI bleed and lower GI bleed. So when you talk of upper GI bleed, you mean bleeding in the duodenum proximally. You talk of lower GI bleed, you talk of bleeding in the jejunum distally, although most of the time it will be referred to bleeding in the large gut. Right, so remember that the main artery that supplies the intestines is the superior mesenteric artery. This is the main artery that supplies the small intestine, superior mesenteric artery. However, duodenum is also supplied by the celiac trunk. How do the small intestines look like histologically? The small intestines are very spectacular in cross-section. What will tell you that you're looking at a slide of the small intestine is the presence of these very long finger-like projections that you see into the lumen of the intestines. We call these long projections the villi. So the presence of villi tell you that you're looking at the small intestines. But you should still be able to distinguish three segments, the three segments of the small intestine histologically. How do we do that? I'll take you through how we distinguish the three segments of the small intestine histologically. I hope you do remember that we mentioned last week that there are four histological layers of the GIT wall. The mucosa consists of lining epithelium, lamina propria. And then it may contain some modifications in the mucosa, fine. It may contain some mucosal glands, fine. And indeed, the glands in the mucosa of the intestines, we gave them a name. We call them the intestinal crypts of Leberkuhn. Those ones are universal for all parts of the intestine, so it will not help you to distinguish them. Although the number of the crypts of Leberkuhn may guide you towards some direction. The jejunum has the most numerous of the crypts of Leberkuhn. But if you've not been seeing them, then your eye may not be very confident in telling that these crypts are so many and these crypts are few. So maybe that's not a reliable indicator to use. But layer 2 is what we call the submucosal layer. And the submucosal layer, we said, is a dense, irregular connective tissue layer that confers strength to the gut wall. It may contain some glands, and that becomes very important then. Told you that there are only two parts of the GIT that contain submucosal glands. One is the duodenum, and the other one is the esophagus. So in this case, we can use the presence of submucosal glands to distinguish the duodenum from the other two segments of the small gut. So that becomes easy. If you see glands in the submucosa, and you've also seen villi. So first, let me say, if you see villi, then you know you're looking at small intestine. But if you see glands in the submucosa, in addition to the villi, then you definitely know this is duodenum, nothing else. It cannot be esophagus because esophagus does not have the villi. It cannot be the ileum or jejunum because those two don't have the glands in the submucosa. I will tell you other ways of distinguishing the other segments of the small bowel, but let's look at the slide of the duodenum first. So we are looking at histological slide of the duodenum, and we see some projections into the lumen. These are the villi. These are lower magnification, so you're not seeing them very projecting, but these are the villi. Perhaps let me give it a higher magnification. And so you see from there, this is the lumen. And so these are the villi, finger-like projections into the lumen. You can see some depressions or clefts. The clefts between the villi are the ones we are calling the crypts of Leberkuhn. Those are particularly mucosal glands. Then you see this junction here, demarcating between the mucosa and the submucosa. But what do you see in this submucosa? This submucosa contains numerous glands. So you see in this end, you've seen the villi, which means this is small gut. Then in the submucosa, you're seeing a lot of glands. So definitely this is the slide of the duodenum. The submucosal glands of the duodenum have a name. We call them glands of Brunner, Brunner. The Brunner's glands are glands which secrete, of course, there'll be water, but it also has mucoid secretion. As you can see, there are mucus glands. And the mucus there is practically to lubricate the intestinal wall against friction. But importantly, this secretion also contains bicarbonate. And perhaps that's the main content of the Brunner's glands. It contains bicarbonate. The secretion has a lot of bicarbonate. The bicarbonate from the Brunner's glands is aimed at neutralizing the acidity that is in the gastric content that is entering the duodenum. Remember, food from the stomach enters the duodenum first. The duodenum is the first segment of the small gut that receives food from the stomach. So as food moves from the stomach to the duodenum, this food has a lot of acidity from the gastric acid, as we mentioned last week. So to prevent, or rather to neutralize this, we have the secretions of the Brunner's glands, which are rich in bicarbonate. Look at layer 3 of the gut. Layer 3 of the gut is what we said was lined by muscularis propria. And muscularis propria, we have two layers. The inner circular layer, you can see this is the circular layer. You see this is a cross-section from the GIT wall, as you can see in this low magnification. It's a cross-section. So if it's a cross-section, then the circular layer, the muscles will appear to have been cut longitudinally. And that's why you're seeing this arrangement there. So this is the inner circular layer of muscles. Then this is the outer longitudinal layer of muscles. The longitudinal muscles will be cut transversely. And that's why they appear like they've been cut in cross-section. Duodenum being not lined by peritoneum, it will only expect adventitia. The adventitia of the duodenum will be very thin, and so that's why we don't even see it in this particular image. The duodenum, because it is not lined by peritoneum, it is not suspended by the mesentery. It is considered to be retroperitoneal. Structures that are not covered by peritoneum are most likely behind the peritoneum, and so they are termed as being retroperitoneal, and duodenum is one of those retroperitoneal organs. We'll be having a lecture on the retroperitoneal organs sometime, but duodenum is one of them. So this higher magnification elaborates further on the glands of Brunner. And what I want you to appreciate is that they are mucus glands, basically. They are mucus glands. And these are the villi. The gaps between the villi are the crypts of Lieberkühn. Like this is a crypt, that's a crypt of Lieberkühn. Right, that's duodenum. How about jejunum? So first we agree that small intestines have villus projections. And so these are the villus projection. The finger-like projections are the villus projections. So we know that we are looking at the small intestine. I don't want you to confuse this big one with the small one. So these small ones are the ones we are calling villi. We can see the way the mucosa has a lot of villi. So we confirm it is small intestine. This slide is not a cross-sectional slide, but a longitudinal slide. And this longitudinal slide shows us something. This blue zone is actually the submucosa. So that's the dense connective tissue layer of the jejunum. First of all, we agree that this submucosa does not contain glands. It's just connective tissue. But what else do we see? The connective tissue of the jejunum, the submucosa of the jejunum, has some folds which appear like that. So these are folds of the submucosa, a fold of the submucosa. And those folds of the submucosa make the mucosa then have that bumpy appearance. So these submucosal folds of the jejunum are not necessarily unique to jejunum. They're actually found in all segments of the small gut. But the folds of the jejunum are very close to one another, so that you don't even have a gap between one mucosal bump and another one. These folds, you don't have big gaps like this one. Okay, even this one is a gap. So you see, these two are still very close to each other. I'll show you one for the ileum and you'll see the way these folds are further apart. Here, you don't even see a gap. Maybe even here, you are not seeing a gap. These folds are called plica circularis. So the point home is that jejunum has numerous plica circularis. Plica is P-L-I-C-A, that is plica. Circularis is from the word circular, then just write circularis. So plica circularis also have another name. Radiologically, we call them the valvulae conventis. Valvulae from the word valves. Conniventis, just write in your mother tongue, conniventis. So you can call them plica circularis or valvulae conventis. They are more numerous in the jejunum compared to any other part. So we can ask ourselves, why is this segment of the GIT not the duodenum? And the answer is this. First of all, there are no submucosal glands. And two, the plica circularis are very intimate in this one. The duodenum doesn't have very close plica circularis as we can see in this one. All right, so this is the muscular layer. So you see, because this section has been taken longitudinally, the inner circular layer now are cut transversely. That's the inner circular layer of muscles. And then this is the outer longitudinal layer of muscles. You can now appreciate that the outer longitudinal layer of muscle is now being cut longitudinally. And in this one, you see another blue layer outside there, very thin, but you see it. You didn't see it in the previous one, but here we can see it. That one is actually the serosal layer. Jejunum is intraperitoneal. It is covered by peritoneum, so it's intraperitoneal. So because it is intraperitoneal, we will be able to see the serosa, and that's the serosa. So that is jejunum. This is just a higher magnification of one of the folds so that you appreciate that these are the villi and that the villi are lined by still epithelium, simple columnar epithelium. I hope you do remember that we said that the epithelial lining of the GIT is simple columnar all the way from the stomach to the rectum. So we see that simple columnar epithelium that is lining the villi there. How about ileum? What do we pick in the ileum? So first, the ileum will still have the villi, and many for that matter. And I'll show you in another slide the way they can be so many. These one are not coming out nicely because it's not a nice cross section. I think it was an oblique section, so the villi have been cut, but these are still villi. So we see villus projections into the lumen. We know that we are looking at small bowel. But what else do we pick in this particular slide that make it unique? These rounded things, we see them. They're usually present in both the mucosa and the submucosa. Those rounded things you see are lymphatic nodules. Yes, we have lymphatic nodules in all parts of the GIT. However, the ileum has numerous lymphatic nodules. The lymphatic nodules of the ileum are known as the Peyer's patches. So the ileum has several Peyer's patches. These are lymphatic nodules of the small intestine, specifically the lymphatic nodules of the ileum, the Peyer's patches. I think I used another term last week. I told you that they are called mucosa-associated lymphatic tissue. You can abbreviate it as MALT, mucosa-associated lymphatic tissue. So how do you pick ileum? It will have several lymphatic nodules. But there's another thing we can still use to pick ileum, and I'll use this other slide to demonstrate that. So these are longitudinal section through the ileum. We confirm the presence of the villi, and so we know that we are looking at the small intestine. Then we note that there are still submucosal folds. However, the submucosal folds are further apart. So we know definitely not the jejunum. And why is it not the duodenum? Because we don't see glands in the submucosa. And the story is home. So even without looking at the Peyer's patches, we are still able to pick the ileum because of how the folds, the plica circularis, are further apart, and the absence of the submucosal glands that makes it ileum. For those with keen eyes, you can see that's a lymphatic nodule, and this is another one, although this one is not a nodule per se. We call it diffuse lymphatic tissue. These are diffuse lymphatic tissue, but that's a lymphatic nodule. The ones which are discrete are lymphatic nodules. The ones which are not discrete are diffuse lymphatic tissue. Appreciate the villi of the small intestine in this one. This is how the villi look like. The gaps between the villi are the crypts of Lieberkühn. So these are the crypts of Lieberkühn. Look at the submucosa. There are no glands there in the submucosa. Then this is the inner circular layer of muscles, been cut transversely because we are looking at a longitudinal section. And this is the outer longitudinal layer of muscles, which have been cut longitudinally. I want us to zoom into the epithelial type of the small intestine just to demonstrate something using ileum as an example. So when you look at this one, it's a simple columnar epithelium. But there's something else you see. Look at the edge of that epithelium and you'll see something like a brush border. That brush border is an important thing in the small intestine, specifically in the ileum. The brush border tells you that you're looking at epithelium that contain several microvilli. So don't confuse villi with microvilli. This big thing is a villus, in plural villi. This brush border contains several microvilli. They appear like a brush border. And when you see microvilli, it tells you that this epithelium is absorptive. We call these cells the enterocytes, the cells which absorb substances. They are called enterocytes. Those columnar epithelial cells are called enterocytes. The moment you see these are microvilli, and this is villus of the small intestine, then you know these cells are the enterocytes, the cells which absorb substances. Okay, so that is the histological structure of the three segments of the small intestine. Let's talk about structural adaptations of the small intestine to its key functions. So first, we know it's very long. its length increases the surface area over which those different functions can happen, definitely. It is also highly coiled. The coiling slows down food substances so that there is more contact time for digestion as well as for absorption. The presence of villi increase the surface area for absorption and of course even for digestion. The microvilli also do the same, increase the surface area for absorption. The muscular wall is very important. We've seen that it has a muscular wall, inner circular layer and outer layer of smooth muscle. The muscular wall contributes to peristalsis. The peristalsis are the contractions which occur in the intestines to move food proximodistally. There's a rich capillary network within the villi. I didn't show you that, but yes, there's a rich capillary network within the villi which promote food absorption. There's extensive lacteal system, again, within the villi. So at the core of the villus, there's an extensive lacteal system. Lacteal system is basically lymphatic system of the villi. This lymphatic system of the villi help in the absorption of fat. And perhaps you'll be taught that in your physiology, that fat does not go into the bloodstream directly from the intestines. Lipids enter the lymphatic system so that we avoid taking a lot of lipids to the liver directly. There's a thin epithelial lining, which is a thin barrier for absorption. The crypts of Lieberkühn are the intestinal glands. These crypts of Lieberkühn produce lubricant, which lubricate food. Well, they may also have some level of bicarbonate, which neutralize the acidity. But importantly also, there are some enzymes which they also secrete. Those enzymes help in digestion of food. And it explains to you why the jejunum will have a lot of them. You know, duodenum receives enzymes from the pancreas for digestion of food. But the jejunum does not have the enzymes from the pancreas unless the ones that are moved distally. So the enzymes in the jejunum are largely produced from the crypts of Lieberkühn, and they still participate in the digestion of food. Then the plica circularis, that's the spelling of the plica circularis. They are folds of the submucosa, which extend into the mucosa. They increase the surface area as well for these functions of the small gut. So that's the story of the small gut. Now let's talk about the large gut. We can call it the large intestine or the large gut. So the large gut consists of a number of things. We have food from the ileum entering the cecum. So the cecum is the first place that receives food. It is the first component of the large gut that receives food. After cecum, food goes to the colon. However, there's an appendix here which is attached to the cecum. Food does not go to the appendix, but this is the best time to mention the appendix as well. So the appendix hangs just below the cecum most of the time. It's a tiny thing, and food does not go there. So from the cecum, food goes to the colon, and from the colon, food goes to the rectum, and from the rectum, food goes to the anal canal or the anus. These five are the components of the large gut. So take note that the appendix is still part of the large gut, even though it's smaller than the small gut. I want us to talk more about the colon. So the colon has a number of segments, 4 of them. On the right side, we have the ascending colon. Then this is the transverse colon. On the left side, we have the descending colon. Then we have the sigmoid colon. There are some bends which are worth noting. The bend between the ascending colon and the transverse colon is called the right colic flexure. And this right colic flexure is just below the liver, and so it's also called the hepatic flexure. Then the junction between the transverse colon and the descending colon is called the left colic flexure. The left colic flexure is just below the spleen, so we also call the splenic flexure. So take note, that is the hepatic flexure, and that is the that is the splenic flexure of the colon. It is important for me to mention to you also at this point that the ascending colon and the descending colon don't have mesentery. So they are retroperitoneal. However, the transverse colon and the sigmoid colon have mesentery. So they are suspended in the abdomen. They have mesentery, so they are intraperitoneal. They have mesentery suspending them. The mesentery of the transverse colon is simply called the transverse mesocolon, and the mesentery of the sigmoid colon is called the sigmoid mesocolon. Ascending and the descending colon don't have mesentery. There are some unique features of the colon that we can use to distinguish the colon from the small gut. Some of them are obvious, and let me start with the obvious ones. One of the obvious things is that the colon has a wider lumen compared to the small bowel. It sounds obvious, but it's true, and I want you to remember it, that the large gut or the colon has wider lumen compared to the small bowel. Another thing I want you to remember is that the large bowel takes peripheral position of the abdomen, while the small bowel takes the central position of the abdomen. The small bowel will be lying here within the central region, but the large bowel takes the peripheral zone. So large bowel is peripheral and small bowel is central. The third difference is based on the coils. The small bowel is highly coiled compared to the large bowel. Now, those 3 differences I've told you are okay, and you can use them when there is no pathology. What I mean is that in cases of pathology, the dynamics there might change. For example, if there is intestinal obstruction, the small bowel can balloon out so big, larger than a normal large bowel. And that I'm saying that those differences I've given you are true, yes, in case there's no pathology. But there's some other differences that you can still use which are not particularly affected by pathology. And one of them is the presence of the tinea coli. What is tinea coli? Tinea coli refers to a longitudinal band of smooth muscle which is present in the colon. If you remember from last week, we said that yes, we have inner circular layer and outer longitudinal layer of muscles, but that outer longitudinal layer of muscles of the colon exist in bands, and those bands are known as the tinea coli. There are usually 3 bands. The tinea coli is apparently shorter than the actual colon. And because the tinea coli is shorter than the actual colon must fold to fit into the length of the tinea coli. Those folds of the colon are known as the circulations or hostrations. So what is unique about these folds? These folds are incomplete. They are not complete folds because the region of the tinea has no fold. But the region where there's no tinea, there's a fold. So they are not complete folds. This distinguishes them from the ones of the small intestine. The plica circularis of the small intestines are complete circular rings of the small intestine. But the folds of the large gut are hostrations. They are incomplete folds. The third difference is that there are numerous tags of fat which are on the large gut. We call them appendices epiploci or omental appendages. So use this to make it unique for the large gut. In case there's pathology or there's no pathology, these ones don't change. Remember, the key function of the large gut is basically absorption of water and minerals. Now, let me take you through the blood supply to the large gut. The large gut is partially from the midgut and partially from the hindgut, embryologically. And so for that reason, the large gut will be supplied by both branches of the superior mesenteric artery as well as branches of the inferior mesenteric artery. The superior mesenteric artery supply the segments of the large gut which are from the midgut, which are specifically the cecum, appendix, ascending colon, and part of the transverse colon. So those regions are supplied by branches of the superior mesenteric artery. Then the rest of the large gut are supplied by branches of the inferior mesenteric artery. When we come for the practical, you'll appreciate these vessels better, and you'll even talk about some details about the anastomosis of the large gut. So point to note is that large gut receives branches from both superior as well as inferior mesenteric artery. The veins which come from the intestines, whether small intestine or large intestine, eventually join to form what we call the portal vein, which takes blood direct to the liver. So blood from the intestines go to the liver. Remember, it's deoxygenated blood, but it contains nutrients or water or minerals that have been absorbed. Let's finish with the histological organization of the large gut. So this is how the lumen of the colon would look like histologically. Or rather, this is how the colon would look like histologically. What needs to pick your attention first is the presence of some 3 bumps, that one, and that one. These are the tinea coli. We've agreed that yes, we need to have inner circular layer and outer longitudinal layer of muscles. The outer longitudinal layer of muscles of colon exists in bands, and those are the 3 bands we're talking about. These bands are known as the tinea coli. A closer look into the wall demonstrates that. So this is one tinea coli, outer longitudinal band of muscle. This is the inner circular layer of muscle, it's continuous. This is the submucosal layer. You can see it's just connective tissue, there are no glands. This is the mucosa. Now, what is unique about the mucosa? We don't see villi, but what do we see? Maybe a higher magnification will show you that. There are no villi here. But we still have the crypts of Lieberkühn. These are the crypts of Lieberkühn. Those depressions which go through the mucosa, that the ones called the crypts of Lieberkühn. The intestinal glands. They are mucosal glands. But importantly also for colon, in addition to the absence of the villi, the cells that line the crypts of liver, look at them. They are more mucus cells. The goblet cells are more here compared to the ones of the small gut. So that's the point, that the crypts of the large gut are lined by more mucus cells. The mucus cells are more in the large gut compared to the small gut. And then we've said that the large gut does not have the villi. So what you're seeing here are mucus cells, what we call goblet cells, which usually line the crypts. Like these are all mucus cells. Okay, so that is colon. How would the appendix look like? So for the appendix, in cross-section, it may give you the impression that you're looking at the ileum because of these numerous lymphoid nodules. It has several Peyer's patches as well. However, how do you distinguish the two? For the appendix, the lumen does not have villi. Then you know that's how the appendix, you're looking at the appendix. So we see numerous lymphatic nodules, and there are no villi. And then it is not colon because here we don't see the tinea coli. That's how the appendix will look like. Great. So that's what I wanted to take you through today. Basically looking at the anatomy of the whole GIT part 2. So next week we'll pick from there. We'll be looking at anatomy of the exocrine glands. We'll also describe the splanchnic circulation, and in the process we'll also talk about what we call portosystemic anastomosis. If you have time between now and next week, you can read on portosystemic anastomosis and their clinical importance. We'll be doing that next week. So we'll stop there for today and allow you to ask questions if you do have